Medications for congestive heart failure, CHF. Introduction. Congestive heart failure, CHF, is a chronic and progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs for blood and oxygen. This leads to symptoms such as shortness of breath, fatigue, and swelling, significantly impacting a patient's quality of life and prognosis. While lifestyle modifications are crucial, medications form the cornerstone of CHF management, playing a vital role in alleviating symptoms, slowing disease progression, improving heart function, and extending life expectancy. This article provides a comprehensive overview of the primary classes of medications used to treat CHF, detailing their mechanisms of action, therapeutic benefits, and important considerations for their use. Classes of medications for CHF. ACE inhibitors and ARBs help relax blood vessels and reduce the heart's workload. Beta blockers slow the heart rate and improve heart function. Diuretics help remove excess fluid from the body, reducing swelling and improving breathing. Aldosterone antagonists help regulate fluid balance and lower blood pressure. ARNIs, angiotensin receptor blockers and neprilysin inhibitors. SGLT2 inhibitors. Soluble guanylate cyclase, SGC, stimulators. Digoxin can help strengthen heart contractions and regulate heart rhythm. Vasodilators, e.g., hydralazine, relax blood vessels, reducing the heart's workload. ACE inhibitors. ACE inhibitors play a key role in treating heart failure, particularly in cases of heart failure with reduced ejection fraction, HFrEF. These medications help reduce the heart's workload, enhance blood flow, and lower both mortality rates and disease progression. ACE inhibitors work by lowering blood pressure through the inhibition of an enzyme called angiotensin-converting enzyme, ACE. This enzyme normally converts angiotensin I, an inactive hormone, into angiotensin II, an active form that constricts blood vessels, raising blood pressure. By blocking ACE, these drugs decrease the production of angiotensin II, leading to the relaxation and widening of blood vessels, vasodilation. This, in turn, makes it easier for the heart to pump blood, resulting in lower blood pressure. Generally, ACE inhibitors do not significantly affect heart rate and are considered heart rate neutral. Their primary effect is on blood pressure. However, in certain cases, such as with specific drug interactions or underlying health conditions, a decrease in heart rate may occur. Common examples of ACE inhibitors include lisinopril, enalapril, Vasotec, and ramipril, Altase, with most ACE inhibitors having generic names that end in pril. Angiotensin II receptor blockers, ARBs. Angiotensin II receptor blockers, ARBs, are similar to ACE inhibitors in that both target the effects of angiotensin II, a hormone that increases blood pressure and strains the heart. The key difference lies in how they work. ACE inhibitors reduce the production of angiotensin II by blocking the enzyme responsible for its formation, while ARBs block angiotensin II from binding to its receptors on blood vessels. Despite this difference in mechanism, both drug classes produce similar therapeutic effects, including lower blood pressure and reduced strain on the heart and kidneys. ARBs are often prescribed for patients who are unable to tolerate ACE inhibitors, often due to side effects such as persistent cough. Examples of ARBs include losartan, Cozar, valsartan, Diovan, and candesartan, Atacand. Like ACE inhibitors, ARBs are generally heart rate neutral, meaning they typically do not cause significant changes in heart rate. However, in certain cases, such as during drug interactions, in individuals with a high resting heart rate, or under anesthesia, a decrease in heart rate may occasionally occur. Beta blockers. Beta blockers are a key treatment for managing congestive heart failure, especially in patients with reduced ejection fraction, HFrEF. These medications help by slowing the heart rate, lowering blood pressure, and blocking harmful stress hormones, all of which reduce the heart's workload and improve long-term outcomes. Beta blockers target two main types of receptors, beta-1 and beta-2. Beta-1 receptors are primarily found in the heart and kidneys. Blocking these receptors slows the heart rate, reduces the force of heart muscle contractions, and lowers blood pressure, which decreases the heart's oxygen demand and overall strain. Beta-2 receptors, on the other hand, are located in smooth muscles of the airways and blood vessels. Non-selective beta blockers can affect both beta-1 and beta-2 receptors, potentially causing side effects such as airway narrowing. In heart failure, the benefits of beta blockers come primarily from their action on beta-1 receptors in the heart. However, not all beta blockers are appropriate for heart failure treatment. Only specific ones, carvedilol, Coreg, bisoprolol, Zabita, and metoprolol succinate, Toprol XL, are proven to be effective and are approved for use in heart failure management. Carvedilol is a non-selective beta blocker, meaning it blocks both beta-1 and beta-2 receptors. While effective, this broader action can lead to more side effects, especially related to the lungs and airways. Bisoprolol is the most selective of the three, primarily targeting beta-1 receptors. This selectivity theoretically reduces the risk of side effects, particularly those related to the lungs, making it a good choice for patients who may be sensitive to non-selective beta blockers. However, individual responses can vary, and some patients may still experience side effects, even with the more selective options. Metoprolol succinate, Toprol XL, is also selective for beta-1 receptors, offering a more targeted approach with a similar profile to bisoprolol, though individual responses will vary. Important considerations. Gradual introduction. Beta blockers must be started at a low dose and gradually increased over time. This slow titration helps the body adjust and reduces the risk of side effects. The process typically spans several weeks to months and should be closely monitored by a healthcare provider. Never abruptly discontinue. It's crucial not to stop taking beta blockers suddenly, as doing so can worsen heart failure symptoms and increase the risk of severe heart complications. Always consult your doctor before making any changes to your medication. Use only those recommended. Not all beta blockers work. To ensure safety and effectiveness, it's essential to use only those beta blockers recommended for heart failure and to follow the prescribed instructions regarding dosing and follow-up care. Diuretics. In CHF, the body's compensatory mechanisms, such as the activation of the renin-angiotensin-aldosterone system, RAAS, and the release of antidiuretic hormone, ADH, exacerbate fluid and sodium retention. While intended to increase blood volume and pressure, these processes overwhelm the weakened heart, leading to congestion in the lungs and peripheral tissues. Diuretics, also known as water pills, become essential to counteract this retention. By reducing the fluid overload, diuretics can relieve shortness of breath. Excess fluid can build up in the lungs, making breathing difficult. Reduce swelling. Edema. Fluid retention often causes swelling in the ankles, legs, and abdomen. Decrease the workload on the heart. By lowering the amount of fluid the heart has to pump, diuretics make the heart's job easier. Potassium-sparing diuretics. These diuretics help remove excess fluid from the body while also preventing the loss of potassium. They work in the distal part of the nephron. Some block the action of aldosterone, a hormone that causes sodium retention, while others directly block sodium channels. Common uses, often prescribed in combination with thiazide or loop diuretics to counteract potassium loss caused by those medications. Also used for heart failure, hypertension, and conditions with excess aldosterone, e.g., Conn syndrome. Examples: spironolactone, aldactone, eplerenone, Inspra, amiloride, midamor, triamterene, thyrendium. Side effects can lead to high potassium levels, hyperkalemia, especially when used alone or with other potassium-raising medications. Spironolactone can also cause gynecomastia, breast enlargement in males, and erectile dysfunction. Thiazide diuretics. These work by inhibiting sodium and chloride reabsorption in the distal convoluted tubule of the kidney. This leads to increased excretion of sodium and water, and also causes blood vessels to relax, contributing to lower blood pressure. Common uses, primarily prescribed for high blood pressure, hypertension, mild to moderate edema, fluid retention, associated with heart failure, and sometimes to prevent kidney stones, by reducing calcium excretion. Examples: hydrochlorothiazide, chlorthalidone, indapamide, metolazone. Side effects can lead to low potassium, hypokalemia, increased blood sugar, increased uric acid, potentially triggering gout, low sodium, hyponatremia, and sun sensitivity. Loop diuretics. These are powerful diuretics that act on the loop of Henle, inhibiting the reabsorption of sodium, potassium, and chloride. They cause significant fluid loss. Common uses, used for more severe fluid retention, particularly in conditions like heart failure, especially when it causes shortness of breath, liver cirrhosis, kidney disease, including nephrotic syndrome, and high blood pressure when other diuretics are insufficient. They are very fast-acting. Examples: furosemide, Lasix, bumetanide, Bumex, torsemide, Demodex, ethacrynic acid, Edecrine. Side effects can cause significant potassium loss, hypokalemia, low sodium, low magnesium, hypomagnesemia, dehydration, and rarely, ototoxicity, hearing damage. They can also raise uric acid levels. Osmotic diuretics. These agents are non-reabsorbable substances that increase the osmolarity of the blood and renal filtrate, drawing water into the urine by osmotic pressure. Common uses, typically used in acute, urgent situations, such as reducing intracranial pressure, swelling in the brain, treating cerebral edema, or reducing intraocular pressure in glaucoma. They can also be used to prevent acute renal failure during surgery. However, they are generally contraindicated or used with extreme caution in patients with active heart failure due to the risk of extracellular volume expansion before diuresis, which can worsen fluid overload. Examples: mannitol, isosorbide. Side effects can lead to extracellular volume expansion, which can be problematic in heart failure, headache, nausea, vomiting, and dehydration. Carbonic anhydrase inhibitors. These drugs inhibit the enzyme carbonic anhydrase, primarily in the proximal tubule of the kidney. This leads to increased excretion of bicarbonate, sodium, and water. Common uses. While having a weak diuretic effect, they are mainly used for conditions like glaucoma, to reduce fluid in the eye, epilepsy, and sometimes for altitude sickness. Examples: acetazolamide. Side effects can cause metabolic acidosis, kidney stones, hypokalemia, and drowsiness. Diuretic use should be closely monitored, as they can cause electrolyte imbalances. This may lead to systemic muscle loss, which weakens the heart muscle and creates a vicious cycle that exacerbates congestive heart failure, CHF. Aldosterone antagonists. Aldosterone antagonists are a class of medications that work by blocking the effects of aldosterone, a crucial hormone produced by the adrenal glands. Aldosterone's primary role is to regulate blood pressure and fluid balance in the body by signaling the kidneys to retain sodium and water, which consequently increases the volume of blood circulating in the bloodstream. By inhibiting aldosterone's action, these drugs lead to a cascade of effects, primarily within the kidneys, resulting in increased excretion of sodium and water, This increased fluid removal through urine directly reduces the total volume of blood the heart has to pump, thus lowering blood pressure. Retention of potassium. Aldosterone normally promotes potassium excretion. Blocking it leads to potassium retention, which can be beneficial in some cases but also carries the risk of hyperkalemia, high potassium levels, a potentially serious side effect that requires monitoring. Beyond their impact on fluid balance and blood pressure, aldosterone antagonists can also influence electrolyte balance. Besides potassium retention and sodium excretion, they can potentially affect magnesium levels. Kidney function. While beneficial in some kidney conditions, they require careful use in individuals with pre-existing kidney issues. Newer agents like phenylenone are being investigated for kidney protective effects in specific patient populations. Cardiovascular system. Beyond lowering blood pressure, they can help reduce cardiac fibrosis and remodeling, improve endothelial function, and decrease vascular stiffness. Endocrine system, particularly spironolactone. Some, like spironolactone, can have anti-androgen effects, leading to hormonal side effects such as gynecomastia, breast tenderness, and menstrual irregularities. Newer agents like eplerenone and phenylenone are more selective and have a lower risk of these hormonal side effects. Heart rate. Indirectly, while not a primary heart rate medication, they can indirectly influence it through reduced cardiac workload and potential improvements in heart rate variability. However, a significant concern is that severe hyperkalemia, a potential side effect, can lead to a slow or irregular heartbeat. Common examples include spironolactone, eplerenone, and phenylenone. Their use is indicated for conditions like hypertension, heart failure, and fluid retention, and requires careful medical supervision due to their potential impact on various bodily functions. ARNIs. ARNIs stands for angiotensin receptor neprilysin inhibitors. They are a class of medications primarily used to treat heart failure, particularly heart failure with reduced ejection fraction, HFrEF. ARNIs combine two types of drugs into a single pill. Angiotensin II receptor blocker, ARB. This component, like valsartan, found in the common ARNI Entresto, blocks the action of angiotensin II, a hormone that narrows blood vessels and causes the body to retain salt and water. Neprilysin inhibitor. This component, like sacubitril, also in Entresto, inhibits neprilysin, an enzyme that breaks down natriuretic peptides. Natriuretic peptides are beneficial hormones that promote the excretion of sodium and water in the urine, reducing blood volume and pressure. Widen blood vessels. Have favorable effects on the heart. The primary use of ARNIs is to treat heart failure with reduced ejection fraction, HFrEF. Studies have shown that in these patients, ARNIs can reduce the risk of hospitalization for heart failure, decrease the risk of cardiovascular death, improve symptoms and quality of life, help patients live longer, improve the heart's pumping function, ejection fraction, over time. Important considerations. ARNIs should not be taken by pregnant women. There is a washout period required when switching from an ACE inhibitor to an ARNI, usually 36 hours, to reduce the risk of angioedema. Patients taking ARNIs should avoid potassium supplements and be cautious with salt substitutes containing potassium unless advised otherwise by their doctor. Regular monitoring of blood pressure, kidney function, and potassium levels is usually necessary. The most common ARNI currently available is sacubitril/valsartan, sold under the brand name Entresto. SGLT2 inhibitors. Sodium glucose cotransporter 2, SGLT2, inhibitors are a class of medications that were initially developed for the treatment of type 2 diabetes but have emerged as a foundational therapy for heart failure, demonstrating significant benefits regardless of a patient's diabetic status. Mechanism: SGLT2 inhibitors work by blocking the SGLT2 protein in the renal, kidney, tubules. This protein is responsible for reabsorbing most of the glucose and a significant portion of sodium back into the bloodstream from the filtered fluid. By inhibiting SGLT2, these drugs cause increased excretion of glucose and sodium in the urine, glycosuria, and natriuresis. This leads to an osmotic diuretic effect, contributing to fluid reduction. However, their profound benefits in heart failure extend beyond simple diuresis, involving complex improvements in cardiac metabolism, kidney function, and inflammation, distinguishing them from traditional diuretics. Common uses: SGLT2 inhibitors are now recommended for patients with heart failure with reduced ejection fraction, HFrEF, and heart failure with preserved ejection fraction, HFpF. They significantly reduce the risk of cardiovascular death and hospitalizations for heart failure, and can also slow the progression of kidney disease. Examples: common SGLT2 inhibitors used in heart failure include dapagliflozin, Farxiga, and empagliflozin, Jardiance. Sotagliflozin, Inpefa, is also approved for heart failure. Side effects: common side effects can include genitourinary fungal infections, e.g., yeast infections, urinary tract infections, increased urination, and dehydration. Rarely, more serious side effects like diabetic ketoacidosis, even in non-diabetic patients, or Fournier's gangrene, a rare genital infection, can occur. Blood pressure may also decrease. Soluble guanylate cyclase, SGC, stimulators. Soluble guanylate cyclase, SGC, stimulators are a newer class of medications used in the management of specific heart failure patients. Mechanism: in heart failure, the nitric oxide, NO, soluble guanylate cyclase, SGC, cyclic guanosine monophosphate, CGMP, pathway is often impaired. NO typically activates SGC, leading to the production of CGMP, which promotes vasodilation, blood vessel relaxation, and has beneficial effects on the heart muscle. SGC stimulators directly stimulate SGC and also enhance its sensitivity to any available NO. This results in increased CGMP levels, leading to vasodilation, improved cardiac function, and reduced adverse cardiac remodeling, scarring, and stiffening of the heart. Common uses: this class, specifically vericiguat, Verquvo, is used in adult patients with symptomatic chronic heart failure with reduced ejection fraction, HFrEF, who have recently experienced a worsening heart failure event, e.g., hospitalization, or need for intravenous diuretics. It is indicated to reduce the risk of cardiovascular death and heart failure hospitalization. Example: vericiguat, Verquvo. Side effects: the most common side effects include hypotension, low blood pressure, anemia, dizziness, and nausea. Vericiguat should not be used in pregnant women. Differentiating HFrEF and HFpF treatment approaches. While many medications for heart failure aim to alleviate symptoms and improve quality of life, the strategies for treating heart failure with reduced ejection fraction, HFrEF, and heart failure with preserved ejection fraction, HFpF, have historically differed significantly, reflecting their distinct underlying pathophysiologies. Recent advancements, however, have introduced therapies beneficial for both. 1. Heart failure with reduced ejection fraction, HFrEF. In HFrEF, the heart's pumping ability is weakened, ejection fraction less than or equal to 40%. The treatment strategy focuses on preventing disease progression, reducing hospitalizations, and improving survival, in addition to managing symptoms. A foundational, quadruple therapy is now recommended for most eligible patients. ACE inhibitors/angiotensin receptor blockers, ARBs, angiotensin receptor neprilysin inhibitors, ARNIs. These are cornerstone therapies that reduce afterload, block neurohormonal activation, and prevent adverse cardiac remodeling. ARNIs, e.g., Entresto, are often preferred when tolerated due to their superior benefits. Beta blockers. These medications slow the heart rate, reduce myocardial oxygen demand, and block harmful effects of sympathetic nervous system activation, leading to improved heart function over time. Mineralocorticoid receptor antagonists, MRAs, aldosterone antagonists spironolactone and eplerenone are used to block aldosterone's harmful effects on the heart and kidneys, reducing fibrosis and fluid retention. SGLT2 inhibitors, dapagliflozin and empagliflozin, are now considered essential for HFrEF, significantly reducing cardiovascular death and heart failure hospitalizations, regardless of diabetic status. Other important considerations for HFrEF include diuretics, loop, thiazide, primarily used for symptomatic relief of congestion, e.g., shortness of breath, edema, titrated to fluid status. Hydralazine/isosorbide dinitrate. This combination vasodilator is an important alternative or add-on for specific populations, particularly African Americans, who may not tolerate ACE inhibitors/ARBs/RNIs or who remain symptomatic despite optimal conventional therapy. Soluble guanylate cyclase, SGC, stimulators, vericiguat, considered for patients who have recently experienced a worsening heart failure event to further reduce the risk of cardiovascular death and hospitalizations. Digoxin, used in selected patients for symptom control, particularly those with atrial fibrillation, who remain symptomatic despite optimal foundational therapy. Two, heart failure with preserved ejection fraction, HFpEF. In HFpEF, the heart muscle is stiff and doesn't relax properly to fill with blood, despite having a relatively normal pumping ability, ejection fraction greater than or equal to 50%, often with an intermediate range of 41 to 49% referred to as HFmEF. Treatment has historically focused on symptom control and managing comorbidities, as disease-modifying therapies were lacking. However, recent evidence has changed this landscape. SGLT2 inhibitors, this class, e.g., empagliflozin, dapagliflozin, is now the first and only class of medication with strong evidence to reduce heart failure hospitalizations and cardiovascular death in patients with HFpEF, making them a foundational therapy regardless of diabetic status. Diuretics, loop, thiazide, crucial for symptomatic management of congestion and fluid overload, titrated to achieve euvolemia, normal fluid status. Management of comorbidities. Aggressive management of coexisting conditions is paramount in HFpEF. This includes hypertension control, using ACE inhibitors, ARBs, beta blockers, or other antihypertensives as needed to achieve blood pressure targets. Atrial fibrillation, rate and rhythm control are important. Obesity, diabetes, sleep apnea, renal dysfunction, addressing these significantly impacts outcomes in HFpEF. Mineralocorticoid receptor antagonists, MRAs. While the evidence is not as strong as in HFrEF, MRAs may be considered in selected HFpEF patients, particularly those with elevated natriuretic peptides or prior heart failure hospitalization. Key distinction: while diuretics are universally important for managing symptoms of fluid overload in both types of heart failure, the primary disease-modifying therapies that improve prognosis and reduce events have historically been different, with SGLT2 inhibitors now bridging this gap by demonstrating benefits across the entire spectrum of ejection fraction. Personalized care based on a patient's specific ejection fraction and comorbidities is essential for optimal outcomes. Digoxin. Digoxin, also known as digitalis, is a medication primarily used to treat heart failure and certain types of irregular heartbeats, arrhythmias, particularly atrial fibrillation and atrial flutter. It belongs to the class of drugs called cardiac glycosides. Other examples of cardiac glycosides include deslanoside, linaclotide C, and acetyldigitoxin, but digoxin is the primary cardiac glycoside used in contemporary clinical practice in most parts of the world. The other medications in this class are less commonly prescribed due to factors like longer half-lives, potential for greater toxicity, or the availability of digoxin itself. Digoxin's main action involves inhibiting the sodium-potassium ATPase pump in heart muscle cells. This leads to an increase in intracellular sodium, which in turn causes an increase in intracellular calcium. The higher calcium levels enhance the force of the heart's contractions, improving its ability to pump blood, positive inotropic effect. Additionally, digoxin affects the electrical activity of the heart. It enhances the activity of the vagus nerve, leading to a slowing of the heart rate, negative chronotropic effect, and a slowing of electrical conduction through the AV node, negative dromotropic effect. This is particularly helpful in controlling rapid heart rates associated with atrial fibrillation and flutter. Key uses. Heart failure. Digoxin can improve symptoms like shortness of breath and swelling by making the heart pump more effectively. While not always a first-line treatment, it can be valuable for patients with persistent symptoms despite other therapies. Atrial fibrillation and flutter. It helps to slow down the rapid and irregular heartbeats by affecting the electrical signals in the heart. Important considerations. Digoxin has a narrow therapeutic index, requiring careful monitoring due to the risk of toxicity. Dosage is individualized, and it can interact with other medications. Common side effects include nausea, vomiting, and dizziness. Signs of toxicity can be serious and require immediate medical attention. Effects on heart rate and blood pressure. Digoxin primarily lowers the heart rate. Its effect on blood pressure is less direct and consistent. In heart failure, it might have a neutral or slight blood pressure lowering effect, possibly due to improved cardiac output reducing compensatory vasoconstriction. It is not primarily used as a blood pressure lowering medication. Role in therapy. While not always the first medication prescribed for heart failure, digoxin remains a valuable tool in specific situations. When patients have ongoing symptoms despite other heart failure medications. In managing rapid heart rates associated with atrial fibrillation. When other treatments are not tolerated or contraindicated. The use of digoxin requires careful clinical judgment to balance its benefits in improving heart function and controlling heart rate against the potential risks. It is often used in combination with other heart failure medications, such as those that relax blood vessels, vasodilators, to address different aspects of the condition. While there's a theoretical concern about increased workload potentially exhausting the heart over the very long term, its ability to improve cardiac output and alleviate symptoms often provides significant clinical benefits when used appropriately and monitored closely. Vasodilators. Vasodilators are medications that work by widening your blood vessels. This widening allows blood to flow more easily through the vessels, which in turn lowers blood pressure and reduces the workload on your heart. The term itself breaks down to vaso, referring to blood vessels, and dilator, meaning something that widens. Vasodilators affect the smooth muscles in the walls of your arteries and veins. They prevent these muscles from tightening and narrowing the blood vessels. Different types of vasodilators achieve this in various ways. Direct vasodilators. These medications directly act on the smooth muscle cells of the blood vessel walls, causing them to relax. Examples include hydralazine and minoxidil. Calcium channel blockers, CCBs. These medications prevent calcium from entering the muscle cells of the heart and blood vessel walls. Calcium causes these muscles to contract, so blocking it leads to relaxation and widening of the vessels. Examples include amlodipine and diltiazem. Nitrates. These drugs convert to nitric oxide in the body, which is a natural vasodilator. Nitrates primarily dilate veins and are often used to treat angina, chest pain. Examples include nitroglycerin and isosorbide mononitrate. ACE inhibitors, discussed before. ARBs, discussed before. Common uses of vasodilators. Vasodilators are prescribed to treat a range of conditions, primarily those related to the cardiovascular system, including high blood pressure, hypertension. By widening blood vessels, vasodilators help to lower blood pressure. Angina, chest pain. Vasodilators, particularly nitrates, can improve blood flow to the heart muscle and relieve chest pain. Heart failure, some vasodilators can reduce the workload on the heart and improve blood flow. Pulmonary hypertension, these medications can help lower blood pressure in the arteries of the lungs. Other conditions. Vasodilators are also used for conditions like Raynaud's phenomenon, which affects blood flow to the fingers and toes, and sometimes for erectile dysfunction by improving blood flow. Minoxidil, a vasodilator, is also used to treat hair loss. Important considerations. Vasodilators can have side effects, such as dizziness, lightheadedness, flushing, headache, and increased heart rate. They can interact with other medications, so it's crucial to inform your doctor about all the medicines you are taking. Not everyone is a suitable candidate for vasodilators, and the specific type prescribed will depend on the individual's condition and other health factors. The choice of vasodilator depends on the specific condition being treated, the patient's overall health, and other medications they may be taking. In summary, nitrates are particularly suitable for chest pain due to their rapid ability to dilate coronary arteries and reduce cardiac workload, directly addressing the immediate oxygen supply-demand imbalance causing angina. ACE inhibitors and ARBs, while also vasodilators, have a slower onset and are better suited for long-term management and prevention of cardiovascular events. Conclusion. Effective management of congestive heart failure relies on a comprehensive and individualized approach, with a diverse array of medications playing a pivotal role. As we've explored, therapies like ACE inhibitors, ARBs, beta blockers, and aldosterone antagonists have long been mainstays, significantly improving outcomes for patients, particularly those with reduced ejection fraction, HFrEF. The advent of newer agents such as ARNIs, SGLT2 inhibitors, and SGC stimulators has revolutionized treatment, offering enhanced benefits and, notably, providing the first disease-modifying therapies for heart failure with preserved ejection fraction, HFpEF. Diuretics remain essential for symptomatic relief across all types of CHF, while digoxin and vasodilators address specific needs. This evolving landscape of pharmacotherapy underscores the importance of a nuanced approach, recognizing the distinct treatment strategies tailored to a patient's specific heart failure phenotype. Ultimately, the goal is to alleviate symptoms, prevent disease progression, reduce hospitalizations, and improve quality and length of life. Achieving these outcomes requires careful diagnosis, precise medication selection, consistent adherence to prescribed regimens, and ongoing, collaborative monitoring by healthcare professionals.